OsteoSignal Episode 6. This is OsteoSignal with Neil D. O'Neill, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Autism has puzzled scientists and divided society for decades. Now the conversation's back in the headlines with presidential candidates, viral TikTokers, and influencers chugging bottles of Tylenol on camera to make a point. But what if we're all looking in the wrong place? What if the real origins of autism and many lifelong neurological and developmental issues trace back not to vaccines or medications, but to the trauma sustained during the birth process itself? In this episode, we're exploring the work of Dr. Beryl Arbuckle, an osteopathic physician whose groundbreaking insights connected early cranial injury, birth mechanics, and neurological development decades before modern imaging even existed. Stay tuned as we unpack her clinical results. Once dismissed by mainstream medicine, may hold the key to understand not just autism, but how early life injuries shape the brain, behavior, and human potential. My name's Neil O'Neill. I'm an osteopathically trained manual physical therapist. I have been studying osteopathic thought process in manual care of patients and understanding how patients and how humans work for many years now, over 25 years. And we just like to explore these topics and really explain that to the general person so they can make better decisions about their health. And joining me is Autumn Mayberry.
Hi, I'm Autumn. I've been taking classes in the osteopathic model and treatments for almost 22 years now, and I've been studying under Neil and some other of our great colleagues and stuff. I treat a lot of pediatrics in my clinic, and so I'm just here to offer my little perspective on some of the things I've been learning as I've studied some of Beryl Arbuckle's writings myself, and also taking Neil's classes. So.
All right. And I'm here. And my name is Brent Mayberry. I'm Autumn's husband, and I kind of represent just your average lay person, so to speak, when it comes to osteopathic manual therapy. And so I'll be chiming in, asking for clarification so that the specific terms or ideas presented here can be understood by a wider audience. So thank you so much, Neil, for doing this. Let's dive in.
Okay, lately, social media and the news cycle have reignited the autism debate, not through science, but through politics. We've got presidential candidates, Trump and RFK Jr., both weighing in, pointing fingers at vaccines, acetaminophen, or Big Pharma. And suddenly, people are filming themselves downing Tylenol like it's a protest. Let's just pause right there. This kind of reaction, whether from outrage or blind allegiance, misses the point. Both sides are looking for a villain, but not a mechanism. But osteopathy was built on mechanisms, on function, structure, and cause. What if we stopped arguing about chemicals and started asking how the body itself was injured, compressed, or misdirected before the first breath was ever taken? Dr. Beryl Arbuckle, one of the great osteopathic physicians of the mid-20th century, did exactly that. She wasn't theorizing from headlines or political agendas. She was working hands-on with infants, observing how cranial strain patterns from different labor and deliveries could alter cerebrospinal fluid flow. It could alter vagal tone and neurological development. Her case reports show that when those restrictions were treated gently, osteopathically, the entire developmental trajectory of the child could change. Speech coordination, social engagement, digestion, all improved. Arbuckle didn't see autism as a genetic inevitability or a pharmaceutical injury. She saw it as a mechanical and physiological imbalance, a disturbance in the body's communication system that began with birth, or the labor surrounding birth. And that perspective changes everything. In this episode, we're going to explore how Arbuckle's osteopathic model reframes the autism conversation, not as a culture war, but as a physiological question. We'll look at how her insights into the cranial base, vagal regulation, and early trauma might explain what modern science is only beginning to uncover about neurodevelopment and inflammation. Let's go deeper into the anatomy, the history, and the hope that comes when we look beyond the noise and back into the body.
So Neil, what is vagal tone?
So vagal tone is, a lot of people have heard of the vagus nerve. So the vagus nerve maintains a certain tone, if you will, a certain level of activity throughout the human body. And if it's properly active, it reacts and then recedes, and then reacts and recedes. So that tone is how active it is over time, appropriately. So good vagal tone is proper responsiveness of the vagal nerve. And so you see all sorts of information on the internet about how to get your vagus nerve to be more responsive. Uh, but you do really want it to be more and less responsive, but more appropriate at all times. And that's really where we see a lot of problems. So we have vagal tone versus sympathetic tone. Do you have enough fight or flight? Do you have too much fight or flight? And the vagus works opposite of that. If you have more fight or flight response, then you tend to have less vagal response, or at least that's the old thinking. What we know now is that actually vagal tone rises with sympathetic tone, so that the sympathetics and the vagus work together to keep you at the optimum of performance, whether that's running from a lion or, beating a deadline or taking care of your children.
Yeah, it's about it being a smart system, right? Like, so it rises to whatever occasion you've got, and it can handle dropping you down again when you don't need to be that keyed up.
Yeah, exactly. Perfect. Perfectly
Yeah.
put.
All right, I just wanted to take that little sidetrack. So that is
Yeah,
what we're
perfect.
talking about today related to, vagal tone?
It very much so is, because the vagus receives the motor neurons of the vagus nerve are in the brain stem, particularly in the medulla. And so the brain stem is receiving information from the body, and then those neurons make decisions about what they believe should happen should happen in the body given that input, and how best to respond to it. And then you get a motor output. So if something's happened to the brain itself, if there's some pressure on it, some irritation, some other problem, or in this case, some uh, injury, if you will, at birth or in labor, then those neurons cannot make good decisions about the information coming in. First off, the information may be scrambled as it comes in, or second off, those neurons' ability to coordinate their response may be scrambled by a birth and labor injury, including uh, C-section. C-section, you don't actually get away from that. One of the things we see is injuries from the skull going through the birth canal, and it's supposed to squish down, and the baby comes out looking a little weird. But as they cry and this, that, the other, the brain case should pop back apart and function properly. But it doesn't always do that if the forces that acted upon it during labor and delivery were too great or too prolonged.
Awesome. Thank you. All right.
Okay, so why don't we talk about that birth process and the neurological patterning that occurs as a consequence of that? So the birth process shapes the cranial base, spinal tension, and early neural flow. And so one of the things that you have to kind of think about is the baby is in the womb, and the womb is a component, is several components together. One of which is the uterus, and the uterus is going to contract to help force the baby through the birth canal. And the birth canal at some point is the cervix, and then the vaginal canal. Now, the baby has to present their head to the cervix. And in order to do that, they actually have to go down into what we call the pelvic inlet, and that the baby's head goes down into the pelvis, that ring of bone. And depending on what that ring of bone is capable of doing, a lot of times we think, oh, we just have this ring of bone and it's always perfect. But that nothing could be further from the truth. People go through and they injure themselves. They'll have a pelvic obliquity. They'll have injured something, whether that's through heavy use or an accident or an injury, even disease process. So, for example, say that something had gone on and somebody's had to have surgery to their uterus, or they have some problem in their pelvic floor, like they fell on their tailbone when they were little, and then they're trying to have a child. And if that pelvic floor or that vaginal canal cannot adapt to the baby coming through there, those forces will act on the baby's cranium. Now, the baby's cranium, by nature, on the inside, has these ligaments, if you will, what we call a dura. And that the dura is not only the covering of the brain, but the internal structure that attaches to the bones of the skull to help protect the brain and hopefully not come apart too far as the baby's coming through the birth canal. Unfortunately, like say there's a pubic bone dysfunction or a tailbone dysfunction, or as we said, like maybe this patient had some kind of surgery to the uterus, like a DNC or something like that. Some normally, not too big of a deal. However, it's caused the birth canal to be harder and less giving than it should be. So now as the baby's coming down through that that birth canal, those forces act on its skull and twist its skull into a place. And if that skull goes too far past where it can come back out of, intervention needs to occur afterwards. Otherwise, that relationship of those bones to each other and that tension on that dura, right? And it kind of looks like a big T when you look at it from back to front. It looks like a T. It's what we call a reciprocal tension membrane. Then the part that goes front to back, named the falx, will go into tension as certain volumes of blood and et cetera come into the brain. And then the side ones, called the tentorium, will decrease. And then vice versa. When the sides of the skull relax, it actually puts tension on that tentorium, the side to side support structure, and the front to back will actually the front to back diameter will actually decrease. So you see this almost like a respiratory mechanism. It almost looks like the brain itself is breathing. And we want this to happen because that's how the body drives cerebral spinal fluid around the brain, down through the spinal cord, and then out into the tissues. So it's actually a very important process. Otherwise, you would just have stagnant fluid around the brain and spinal cord, and inflammation would occur, and that would be irritating. In fact, that's what does happen, is that in certain conditions, inflammation builds up in an area. The cerebral spinal fluid does not flow. In fact, for example, hydrocephaly, when the cerebral spinal fluid cannot exit the skull appropriately, you actually get a buildup of pressure of that cerebral spinal fluid. That's damaging to the brain, as anybody knows somebody who had hydrocephaly will know that headaches, lack of consciousness, etc., can be very dangerous. Actually, comas, and people have died from that. So it's very important to have this cerebral spinal fluid flow. And if this mechanism somehow gets so far out of its operating arena through the birthing process, it needs help coming back. Otherwise, what occurs is a lack of development of the brain. You get either injury to the brain, to the neurons themselves, mild little areas where they might not have oxygen for a little bit, or where they don't get nutrition properly, and so those neurons cannot grow appropriately. And we're going to see the effects of this over the days, weeks, months, even years of the child's life, that we start to see things like motor milestones get missed. Like, why did this child not take up this ability? Or why is this child still so shy? Or certainly as the child gets older and older, did the face grow properly off of the cranium? Because if the cranial mechanism didn't work, then the face can't grow properly off of it. Because that too, the face also is dependent upon the dural membranes being able to give and take. And part of that dural membranes, since they attach to the bones of the skull, all the bones of the skull have to be able to flex in response to each other, right? And so it's not, there's a term of cranial movement, and it's not movement in the traditional sense of you're able to lift your shoulder over your head. They're not joints in that way. What we call them sutures. And these sutures are really more of a flex point for the bones, where they interact but allow an increase in fluid pressure inside. They can accommodate the fluid pressure inside the skull without putting undue pressure on the brain itself. But what if we have a problem in that's left over from birthing, the birth canal, or the labor surrounding that, or even the care thereafter, soon thereafter? Any of those things can cause a problem with this flow of cerebral spinal fluid and hold up the function of the baby's brain. And if that goes on long enough, it's not completely reversible, but you start to lose the potential for how far the brain could have developed. So we're also looking at the potential neurodevelopmental potential of the brain is also lost to a degree. So all through life, you can restore this function to a degree. It would be best if we did that early on.
Now, is that something that Arbuckle observed? Like, did she, the information you just shared with us, is that part of her research? Did she notice, those problems with the dura, or the sutures not being able to flex properly, or does that make sense? My question.
Oh, totally. Exactly. Yeah, precisely. That's exactly what she did. So she was a pediatric physician, and she was obviously there to also help in delivery, and of course soon thereafter. And she became more and more interested in it, and so she was there in the entire process, not only the labor, the delivery, and then taking care of the child immediately afterwards, because she actually ran an osteopathic pediatric university in not university, hospital in Philadelphia, where she had these children coming in who had cerebral palsy, or they had some other problem with them. Now, some of those problems were genetically oriented; they were growth of the neural tube itself, and there's nothing that she could do about that. But what she noticed is that there were certain kids that had problems that showed up regularly. That if when she went and looked at them and said, "Well, why is this kid having this?" They had very regular problems. For example, their skulls would not be rounded, or what she called molded. The molding of their skulls did not occur properly. And molding means that even though the babies might come out of the birth canal, whether they've had a forceps or the use of suction, or even if they were a C-section baby, that they would come out and their heads would not be perfectly rounded. And that usually what happens is a baby comes out, their heads aren't perfectly rounded, and they cry for a bit, and the crying and the struggles, and pretty soon the head slowly but surely pops back out to being fairly rounded and mobile, right? And there are these fontanelles, which are openings in the skull, and then those openings are regularly they're regular, like the one in the front or the back are normal sized, and they're even on both sides, or the one to the left of the skull or the right of the side of the skull, they're even sized, as opposed to having one that's really small and one that's really big. That tells you that there's some obliquity in the brain case. So she noticed this, and she would watch these children as they progressed. And again, with cerebral palsy and this, that, the other, she was able to observe that, if we make sure that head molds properly, then these children immediately start doing better. In fact, we can actually get them much closer to normal than otherwise would have been thought. And then, of course, sadly, she also observed a lot of children die in the labor and delivery. And then, of course, she would go to the autopsies and say, I want to know why. And initially, they thought, well, the cerebral palsy and a lot of these other things are due to hematoma, that we tore the child's head. There was a torn vein in the brain, and basically what we would call a stroke. But in the brain, there would be blood, and this hematoma would have killed the child. But what they found on autopsy is there wasn't nearly as many hematomas in these children who had passed away during the process as they would have thought. So she had to look deeper and closer and say, well, what else is there? What else is going on? Now, here's the interesting thing is that the veins that drain the brain are called sinuses. And so the dural sinuses drain the deoxygenated blood out of the brain. What she found is that this tough mother, that's what dura mater means. Dura mater means tough mother. This protective covering to keep the blood inside the veins and not let it get in, or the dural sinuses, and not let it get to the baby's brain. They didn't tear and allow blood out, but what she found a lot of was that they had actually been strained. They had been pulled beyond their normal means, or they had been tensions had been placed into it such that the tension wouldn't come out, and that actually twisted the veins, and blood could no longer go through there. So there was less hematoma, less bleeding than what she thought she would see, and far more, there was injury, but it was a little bit different kind of injury. And so, of course, as she looked at it, she says, well, that's interesting. I wonder if these dural sinuses and this dural membrane, since it is attached to the skull of the bones, and particularly at birth, it's attached to the, what do we call the basilar bones of the skull. Certain parts of the occiput, sphenoid, temporal, ethmoid, there are some specific bones that's attached to. And if she could alleviate that strain pattern in that dura, the baby would actually, start functioning. In fact, there was one particularly poignant case that she noted several times, was that a baby had been stillborn, wasn't breathing, and they had done all the resuscitative measures that they knew how to do, much like what we do today. And, just out of frustration and losing hope, someone said, well, let's do this movement where we try to get those dural membranes to line back up, and to see if we can't just something, just, any ray of hope. And the baby immediately started breathing as they did that. And so it really became very obvious.
That's amazing.
Yeah, it is amazing. Yeah, it was amazing. They actually saved this baby's life and got it to breathe, and because its brain was able to move blood through it. And certainly the parts of the brain that control breathing, right? The medulla, that part that sticks down close to what we call the foramen magnum, where the brain's going to come out of the skull and go into the spinal cord. And as it turns out, this dural membrane actually goes all the way down the spinal cord and is attached to the tailbone. So this can have a profound effect on the entire central nervous system.
Yeah, it's pretty fascinating. Because you see certain things, at least up until now. We just had this class this last weekend for us practitioners, right? Up in Seattle
Right.
with Neil. And you see these things and you're like, "Oh, I didn't know that was because of this. I didn't know it was because of that." And so now since I've been back, it's been 4 days in clinic now, and I'm looking at this with everybody going, "Gosh," and then you're asking questions, "How was your delivery?" Or, "Well, my delivery was fine, but, I was dropped really right away after I was born," or, things like that you're like, "Oh, that's why your head's doing that," or, "That's why your pelvis is this way, and it seems like it's pulling on the bottom of your ear or the base of your skull there." It's been fascinating to see and how these old stubborn things clear up because we are just getting this dura. Now we have a greater understanding of what it is and how it responds. We can manipulate it a whole lot better, even in adults.
Exactly, exactly. And that's just it is that so her what she said is like, look, cranial molding, the natural ability of the brain case to pop back out to its expected relationships, when that doesn't happen, uh, her and the other osteopaths with her, they, looking at these structures, they said, well, if we help these bones get back into their relationship, we feel that that dural tension has changed, and we see that that neurological system, that the ability to receive information in and to process that information and then to have a motor program come out, all of that improves tremendously. Now kind of getting back to the vagus nerve is one of those main structures that does that. It really runs a lot of the intestinal tract, the cardiorespiratory system. So the vagus nerve is a great place, and of course, it exits the brain case in this basilar portion, where, particularly during birthing and labor, they saw the most. When they saw a problem, that's where the problem was. It caused the most effect. So she certainly looked at this, and so the more that her and her team kind of looked at it and understood, like there are very specific patterns. Now, one of the things was that they realized, like, look, the baby's head has to go through this birth canal, and so the mom's body is very important to understanding, like, what are the forces that act on the head, and then how does the baby present in the birth canal? Not every baby presents perfectly, head down, nose posterior, and then comes, nose down and comes out. Babies actually do go through a somewhat of a spiral as they come down through the canal. And if, where did they begin that spiral, and where were they able to end that spiral? Were they able to complete the spiral, or what had to happen? What excessive pressures had to occur to allow that baby to get out of that birth canal? Which is why we use forceps, which is why we use suction, or in order to or vacuum, to get the babies out through that when they get hung up. So this happens all the time, that babies get hung up, or even it happens naturally and without any extra intervention, that a baby might get hung up for a while, and then something's going on, and eventually, for whatever reason, the baby starts progressing again and they come out. But those kind of injuries uh, and insults then are kind of stored, if you will, in the cranium. And then if that information, or that maladaptation, is not taken care of, it inhibits the brain's ability to develop from that point on. Now, the brain, in an infant, in a newborn, is fairly amorphous. There's no real gyri, which are the little the gyri are basically just the folds in the brain. And the more folds there are, the more surface area there is. That's when we are able to bring more neurons to bear for our intelligence. So the human brain has lots of folds, lots of gyri, uh, which just tells us, how intelligent how intelligent we are capable of being. But in this case, that baby does not have those folds, but those folds need to develop. But if this molding does not happen, this cranial molding does not happen correctly, or this dural membrane is under tension, it won't allow that development. And so, of course, we will start to see developmental delays. We'll see things not progress like they should. Well, we'll see a baby with a poor suck and swallow uh, reflex. They won't be able to latch on properly. There may be a seagull cry, like an odd sounding cry that comes out of them because of a normal baby crying. You're like, okay, that's a baby crying. But if the cry itself sounds odd because it changes the vocal cords, it changes the jaw, it changes the face, uh, the ability to breathe, like as with the baby that was resuscitated. It's like, yes, all those things can be affected by how that brain has pressure on it, and then how that brain can then develop. So And she went further and further with this. She had an entire hospital at her disposal to where they took care of babies like this. And of course, everyone was interested in helping all these babies. So then
So
that's
cool.
the neurodevelopment. Yeah. Okay. So that's so we have our birthing, we have our neurodevelopment, we have that communication coming out. And then behaviors come off of that. So we start with the mechanical aspects of the brain, uh, expanding the neurological, the neurodevelopmental aspect, which goes into behaviors. Then we have complex behaviors arise out of as those neurons interact. But if this baby has something where they're still having pressure on certain neurons, for example, a big one is the temporal lobe, which is where a lot of uh, aspects of our personality come out at. For example, shyness or lack of taking charge, for example, or lack of executive function. If we affect that those areas of the brain where executive function or social interaction come from, then this child will be more shy or less um, valiant, if you will, less willing to jump in and do things. They'll be more sensitive. We get these kids today that are hypersensitive to stimuli, right? All these things that we see can be taken back to this lack of appropriate remolding or molding of the brain case. And Autumn, you see this in the clinic all the time. I think those of us who are therapists and work on patients, there's all sorts of aspects of this that you may not have realized before, but now that you see it.
Yeah, I mean, I see it in the clinic, and I've got kids. My when I was pregnant with my first one, I fell on the stairs, and then my doctor, my DO, OB/GYN decided he was gonna try and pop my pelvis, and he didn't do it quite right. And, when I went to go deliver that baby, weeks later, he had to be delivered forceps. He had the cord wrapped around his neck 3 times, and he's struggled with sensitivity kinds of things. And using these techniques from her, I can tell, when he needs treatment because he's not handling stress very well, or which might be in the form of the little sister or whatever. When we treat him, like, he came with me to this class. He's starting to learn these things too, on Saturday, Sunday, or Friday, Saturday, and now, I mean, he has yet to really lose his temper since we've been done. This has been almost a week,
Wow.
and
Wow.
he's not, he's giving her hugs and telling her he loves her and all this kind of stuff, and the little annoying little sister things don't bug him anymore. And so it's really neat, and he's 14, so that's, I mean, yeah, he went through a lot of treatment, and we've done some things, but this information that we got last weekend with learning more about her, and I've tried to read her books on my own, and coming to the class really helped me, like, put it together and figure it out better, and then see it, and he's developing so much better, and he tells me, he's like, I feel better. I don't feel all this pressure in my head," which before you'd asked him, "Does your head hurt? Do you have pressure in your head?" "No, I'm fine." But he's always had it, right? To some level. And so now taking it off, he's like, "Oh my gosh, I feel so much better. I just feel happier." So that's, I mean, as a mom, that's priceless, right? But
Oh yeah.
so, I see that then, but even in these other little kids too, the ones that have anxiety problems or, other things, that it all gets beneficial by applying these treatment protocols from her.
Right. And medically right now, medicine's saying, oh, well, we're going to give kids medications to make this work better or to help do this or help do that. It would be better if the neurons were able to self-regulate as they're supposed to, rather than bringing an outside way of regulating them. So, for example, like Ritalin for ADHD or any of these things. Uh, yeah, or for kids who are depressed, right? I mean, trying to manage them pharmacologically is very difficult. I mean, the doctors are doing what they can, but it's not the finesse and nuance of what it should be.
It's very
You know,
much a crapshoot by comparison.
it really is, yeah. And it's interesting that Arbuckle she was very humble. She she said, "Look now," and you have to remember that the terms back in the 50s were different, but I'll update the term. We don't cure autism; we restore the function that late developmental. No, we don't cure autism. We restore the function that lets development unfold. Right. And so it really shows us that those early osteopathic case reports, they might kind of sound quaint to our modern advanced ears, but the neuroscience is catching up. We're talking about this like if you look at the 1950s and osteopathy versus the 2020s in neurodevelopmental science that we see today, where there's so much research on vagal nerve function, get glymphatic flow, and neuroinflammation and the role that they play. in how people's brains function. So, for example, the role of mechanical deformation and cytokine signaling in developmental disorders. Uh, you know, modern science is really investigating these now and saying, hey, we're finding a greater and greater interaction between these. That autonomic imbalance over hypersympathetic tone or hypo-parasympathetic tone. That if we don't have our sympathetics and our parasympathetics working together, we don't have health. Furthermore, like structural asymmetry and altered proprioception in autistic children, and how Arbuckle's work predicts these findings. She says that's exactly what they saw. And again, they use different terms than we do. Um, but those are the things she saw then, and that's what we see now. And that our modern science is trying to, come the other way around from the biochemical aspect of it. But sometimes about, form, uh, function is determined by structure, and structure is determined by function, right? There's a mainstay of osteopathic uh, understanding of saying, look, the structure and the function work together to give us what it is that we expect of a normal functioning child and adult. And this is exactly, what osteopathy is speaking about. Is Arbuckle said, look, we have to have the form and function work together, the structure and the function together. So we have science validating what Arbuckle saw with her hands and her brain in the 1950s, and and obviously, on autopsy and the information she was able to glean and compile on her patients. So where does that leave us today? It leaves us needing to go back, listen to Dr. Arbuckle, and figuring out how we can integrate this into our practices to help patients today. And I don't think this doesn't, and she even said this. She says, look, you can't use adult treatment methods on children, but you can certainly use child treatment methods on adults, and they will be very happy for you to do it because it can still be so effective. So even though these people that are past the 8 years of age, when the brain case stops growing, has mostly filled in its function, that doesn't mean that we can't change how it interacts within itself. That you and I and manual therapists can optimize that and can restore vagal functioning or sympathetic parasympathetic balance, and maybe not restore the full arc of neurodevelopment, but at least bring the person back within the realm of functioning better. Like you said with your son, that's actually very amazing to see those kind of results and so quickly, as we only worked on him a little bit, so it's very, very promising.
Yep. Yep. It's
That's
fascinating.
that's really great. Is there anything that parents or families can glean from this discussion that they could apply, in their homes? Maybe they're not practitioners,
Right.
but are there some principles that they can apply?
Yeah, so there are some principles they can apply. Certainly one of the things is that we even spoke about in class is that it's known that in like African grandmothers, I've heard this about Scottish grandmothers, that grandmothers in many groups will hold the grandbabies, but what they'll do is they'll rub their head and kind of mold them between their two hands, trying to make their head quote unquote look pretty. I mean, I will say here's one thing that a lot of people think that they're doing well, as they're saying, yes, my kid's head looks funny, so I'm going to get this helmet that restores how the head looks. The biggest problem with that is that the upper portion of the skull, what we call the squama, are more like membranes and that harden in, and the base of the skull is this harder structure. And while the helmet can restore the proper look of the membranous looking portion, the bottom part is not fixed by that, so it will look right and not function. And so using helmets, and even during Arbuckle's time, they tried surgery, they tried all sorts of things, and they found that unless you change that base of the skull, so the portion of the skull next to at the top of the neck is the most important. That and the portion just behind their eyes on either side. Those are the portions that respond the best to this. So parents themselves should be doing molding, but they can't use tools. They have to use their hands. And anything that's hard, gently, very gently. I think, Autumn, you brought this up, that a friend of ours, John Chappell, pretty fantastic physical therapist who did all sorts of osteopathic work, worked in hospitals with neonates for years. He said, look, when you press on this, you only want to press hard enough. Like, imagine that a butterfly has landed on the baby's skull and that when you push on the butterfly, you only apply enough force to cause the butterfly to bend its knees. So very, very gently, but also, putting your hands in the right place, just above the neck, on the bottom of the skull, and seeing if you can't mold the skull yourself to get it to be soft. All you're looking for is a little bit of softness, like flow of fluid, if you will. So it doesn't have to be tremendous, because again, remember, the younger the baby, these bones are not connected. In fact, the bones of the brain are several pieces. So just a very gentle, light,
So much
like
easier.
so much easier, yeah. When the baby's asleep, when the baby's breastfeeding, just a very gentle, like almost a soft rubbing of those structures on the bottom side of the skull, just above the neck, and including the neck, and including the sacrum. Like that's why overly restrictive, like double diapers. Dr. Arbuckle was dead set against double diapers, saying that holds down the cranial mechanism. Don't do that. So things like that, not doing things where the child has too much pressure on their bottom side, like their tailbone and their sacrum, and also something that doesn't put pressure on their skull. And if it's going to, that you gently rub that out. So, for example, you see a lot of kids with what we call crib head, or what has been called crib head, when in fact she says, "Look, that's not crib head. The crib that occurs because of this dural membrane on the inside pulling forward on the head." So anytime you see that, you say, well, that's being pulled forward. What underneath and to the front of the skull is pulling it that direction, right? So that crib head, that flattened part of the skull, is being pulled that direction. And if you think about that pulling, well, like take the flat part of the head and point a finger straight at it, perpendicular to it, and say, well, what's on the other side of that baby's skull from where I'm pointing? And that's where, like, even if it's their underside of their jaw and throat, and again, very gently. None of this is hard. None of this is rigorous. It's all very gentle, but maybe just a very slow moving, methodical, twisty, turny sort of movement. And you would be doing a tremendous amount to help your baby, because you can affect those flat spots.
And if that doesn't help, I mean, try and seek out someone who's been trained to do it, right? I mean, I've got plenty of patients. I'm not trying to get more patients,
Yeah,
but if you can find someone, and that's the beauty of what it is it's not pharmaceuticals that you just slap one response on everybody. There is the possibility of being able to kind of look at your child and see what happened to it, and then provide a treatment that's custom done for the dural strains that your child experienced. It's possible to do that. And there aren't that many of us that do, but a lot of us that haven't studied Arbuckle, it's kind of a newer thing to go this deep in her, at least for me in the last 22 years, right? But seek out someone who has studied this way and see if they can help out a little bit further. You know,
correct.
it's not going to hurt your child as long as they're being gentle. It's not going to hurt your child, but don't be so quick to, like what we were saying at the beginning, right? Like, don't be so quick to blame somebody or something. Just say, well, maybe.
Or to think it blame you yourself either. It's like
Exactly.
these
Yeah,
things
I
happen.
let 'em on their back too long, or I had this, or I was a working mom, or whatever, right?
Right. Yeah.
But it's just not helpful, and some of the answers are a whole lot more simple, um, and, you know,
And
let's
there are
just
a
work
lot
on
of
that
people out
instead
there
of
providing,
other
yeah,
stuff.
there are a lot of people out there doing cranial work. Now, not necessarily Arbuckles, and maybe not to her level, but something is better
Sure,
than nothing. And as you say,
right?
it's better than appliances, and it's better than pharmaceuticals, or waiting until your child needs pharmaceuticals. Or like you said, playing that blame game of, oh my gosh, I wish I'd never done that to my children. I shouldn't have had this, or I shouldn't have had that. It's like, I'm not saying some of those other things like vaccinations aren't a problem, but there are many things that are being blamed on vaccination, blamed on acetaminophen, blamed on this or blamed on that, blamed on you being a bad parent. And that's just not the cause. The cause happened to those tremendous forces acting upon the brain case, pushing the brain and the brain case into a certain position that it just couldn't pop back out of. So it's nobody's fault. It just is what it is. And birthing is probably one of the most difficult things every human faces, even if it's a C-section. That's not
Not for
easy either.
sissies.
Yeah, exactly. So there's no blame here. This is
Yeah,
just life and being human. And let's figure out a way to make everybody's life better.
yep, in a much simpler and less invasive way.
Exactly. That
Yep,
it's not harmful or hurtful or have potential really bad side effects. So, yeah, I think that's what we were all interested in providing, is helping provide health to people as opposed to disease treatment. Some of these they're not diseases, folks. They're just natural consequences of something that happened and can be undone to at least some degree. if not quite a bit, as you see with your son, actually pretty amazing. And just one treatment of applying her principles and following it through logically and going, oh, I see what she was saying. I see with, 30, 40 years of experience and hundreds and hundreds and hundreds of children that she treated, obviously thousands, but she came up with these ideas and progressed them to such a state that even just with the little bit we've learned of her stuff, it's just amazing how quickly you can change children's skulls and their lives.
Yep. Yep. Grateful for her and for you for teaching it.
She's difficult to understand, but
Yes.
but yes, but a lot of this, anybody who there's a saying about any technology that's advanced enough uh, appears to be magic, and some of her stuff appears to be magic. You're like, how could she
It
possibly know all that?
yes. Yep.
but but then as you start to get into it and start to go through the like learn the ABCs of Arbuckle, it becomes more and more obvious of like, oh.
Yeah.
Yeah.
It's
Very
a beautiful
cool.
thing.
Like, I don't know if you want to talk more about how what her work does concerning, like, specifically autism. I don't know if we.
Well, autism, ADHD, anxiety,
Digestive
social,
stuff,
uh,
learning
eye,
issues.
ears, nose, and throat,
Yeah.
all those
Do
things.
do you feel like we connected the dots sufficiently between her studies and work and, like, autism or, those things that you mentioned?
I think we did a fairly good job. I mean, I have many more pages that I could go through, but
Okay. Do you wanna
well,
do a part 2?
we could always. How about I just do a closing reflection?
Okay.
Why don't I
I
just
mean I
run through
mean,
that because
we
it's
don't
pretty
have to
short.
do yeah. I mean, we don't have to do a part 2, like, next week, but we could do a part
Yeah,
2
we could always
down
do
the
it part
road.
two because I think we'll all
Yeah.
learn more. Autumn and I will get
Yeah,
further
once
in
we
this
get the
one.
next step, we're gonna be like,
I know.
"Wait,
Wait
we
till
gotta tell
that.
everybody this too."
Okay, so in closing, I really want to just return to what Arbuckle stood for: curiosity, compassion, and cause. Her cause was helping children and taking care of them. It's not about blame or political allegiance. It's about physiology. It's how how these things progress and function and how they're supposed to, and sometimes they go awry. Um, and Arbuckle would say, what does this child's body remember from birth, and what do we need to help it forget? So practitioners should listen with their hands, not their headlines, and really jump in and try to help restore the normal function of the bones of the brain or the bones of the skull. Uh, and then how does the cranial base compression affect vagal tone and emotional regulation? That's an important thing. Again, vagal tone is highly important. We've talked about that in other podcasts. All sorts of people are talking about that. This is one of the ways that you can help the child regulate their own vagal tone without having to do any odd tapping or this, that, the other. It's just restore the neuron's ability to respond to their environment appropriately, which then leads us to these higher order um, behaviors like emotional regulation. Is the child able to emotionally regulate themselves? Also, one of the other places that you don't see it is that brain case then goes into the face of the ears, eyes, nose, throat, hearing, speaking, all that other stuff then comes off of this. So that actually may be covered in a future episode where we speak more and more about those aspects of it. But just understanding that that's where the promise of Arbuckle leads us to is the ability to help people with all these problems.
Yep, I think it's great. It's just, there's hope. That's what I mean as a mom and as a practitioner both. I'm like, man, I don't have to have these patients that come in and they just are really struggling with these problems and think, I've tried this, I've tried that, and they're so frustrated. They're so, they come in and sometimes say, I just don't want to do it anymore, you know? And you think, well, you don't have to, you know. It's there's still that because it's maybe not be 100% fixable, but we can help you cope a whole lot better. So
Exactly. And have the parents who are just at wits end and they don't know what to do and they're trying to find those answers, having an idea of like, oh, this is normal physiology that's gone awry because of something happened, and that it should be fairly easy to restore that and return their baby to their natural function, as opposed to worrying about all those other aspects of it, of blame and what else. Oh, geez, did I do something wrong? Should I sue the doctor? I mean, it's not always about those things.
and it's not etched in stone. It can change. Things can
It's
get a
changed.
lot better.
Neuroplasticity. Remember that the neurons are very plastic. They can grow, they can respond. So even if they're way behind on their neurodevelopment, it's not like they can't catch up in a hurry. The nervous system is very plastic.
Yeah. I don't know if this is we could push this in somewhere, but years ago after I had my first class from Chappie, the ones that I sent you those things for, um, I had a guy come in to the clinic. His mom had scheduled an appointment. He was 28 years old. He was sleeping at least 20 hours a day in his mom's basement, and he came in and he was just pale and gaunt, really tall, and just, I mean, not thriving at all, right? And he came in and was talking to me about stuff, and Chappie had mentioned, this is like a third push baby thing, and I'm thinking, God, this guy sounds like a third push baby. So we called his mom, and I was like, can you tell us anything about his delivery? And she's like, "Oh yeah, I mean, it was a horrible, horrible long delivery." And then finally, it was just like 3 pushes, and he was out. And I was like, "Thanks, that's what we need to know." And I treated him at 28 like a third push baby. He got out of his mom's bedroom, or out of her basement, went to college. He now has a master's degree, and he has 3 kids, and he's happy. And he filled out and looks like a normal, like, I mean, he's actually a handsome kid, you know. And that's, I mean, been 10 years in the making, right? But even at 28, there was still hope for that kid. And the mom was desperate, and I treated him 3 times.
Which really shows you
And that was
these,
before I even understood this stuff.
exactly, which really shows you that these techniques are useful for all of our clients, all people that might have some birth, labor and delivery injury or peri-birth, peri-labor injury. We can still make changes on those people.
Yep. And it can change their lives, really.
Yes. Awesome. All right.
All right.
Thank you, guys. I'll talk to you later.
Yep. We'll see ya.
Thanks. See you, Neil. Bye.
Thanks for joining us on another episode of OsteoSignal with Neil D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neil D. O'Neill.